Hi, everyone. This is the part that I promised you that I would put up and narrate for Intro to Sepsis, which we didn't get to in a lot of classes. So sepsis is an acute associated organ failure, systemic kind of thing, complication that happens with infection. Everything starts getting worse, and the bacteria does not stay contained in the area for which is infected, the skin, the bladder, the lungs, wherever it is. Now it's in the circulatory system, so it's in the blood. So the bacteria and toxins start circulating in the blood. And what happens is what they call SIRS, or SIRS, a systemic inflammatory response syndrome, which is a precursor to sepsis. And what this causes is, if you remember what inflammation, the steps with inflammation, vasodilation. So those, those blood vessels get bigger. Okay, they spread out, and then increased capillary permeability, where the fluid actually starts leaking out into the interstitial space, or those third spaces. And then something else happens called hypercoagulability. In other words, now because the fluid has leaked out, all these platelets, all the things start bumping together and can start forming clots. Okay, so what happens is all the functions of the cells that normally help the body have an exaggerated and uncontrolled release of chemical mediators system wide. So the histamine, all that kind of stuff is traveling and saying, we've got inflammation everywhere. So vasodilate, increase the capillary permeability. So what happens when blood vessels, specifically arteries, vasodilate? Okay, it's going to cause a drop in blood pressure. Also, the increased capillary permeability is going to drop the blood volume, which also drops the blood pressure. Okay, so we're going to see a low blood pressure. And of course, the vital signs machine always shows you a number next to it. And that's the mean arterial pressure. It's not the MAP, just like it's not the bun. So mean arterial pressure. Okay, and it should be between 70 and 100. That tells you, yes, this patient's body is getting perfused nicely. Okay, so we don't need the vital signs machine to tell us what a mean arterial pressure is. We can go ahead and work that out for ourselves, and it's 2 times the diastolic pressure of the patient plus their systolic pressure divided by 3. Okay, so if they have a blood pressure of 90 over 40, okay, so 40 and 40 is 80 plus 90, okay, is 170. So divided by 3, you're going to get, less than 60. Okay, so even if it's 90 over 50, okay, you're looking at 190 divided by 3, so it's going to be a little over 60. So it's still less than 70. So we really need to take a look at all those blood pressures that have systolics less than 100, okay, and look at those mean arterial pressures, because those patients could not, can start having the cues for sepsis if they haven't already. So one of the other cues is they're either going to have very low temperature, or they could have a fever. Okay, so don't get caught up in, well, what's the elderly usually have a lower temperature. Yeah, that's fine. But, make sure it's not too low. Okay. Make sure it's not too low. Tachycardia and tachypnea. Okay. So because of the vasodilation, the low blood pressure, and the increased capillary permeability, the extremities that are saying, look, I'm not getting perfused. I need oxygen. You have to pump faster, heart. So the heart starts pumping faster, and the heart's like, I'm pumping as fast as I can. And the extremities are saying they're still not getting enough oxygen. So lungs, you're going to have to increase that respiratory rate. So they increase the respiratory rate. Okay. So, take into consideration all these things. Also, a change in level of consciousness. We're not talking about just the elderly. We're talking about for everyone. They'll have a change in level of consciousness. They can start out with very mild confusion and oh, I'm mistaken or this or that. But start honing in on these things, because when I've been talking about cellulitis and TB and UTI, and you can, wrap up with pneumonia and whatever else, okay, they can end up, with just small cues of, changing in level of consciousness. Before you know it, they're in full blown confusion. And we, now we're seeing the other signs, we're paying attention to them. So we need to start looking at that. Like I said, the low blood pressure definitely needs to be one of those things that we need to trend their blood pressure, their systolics as well as their diastolics, to see if they're outside the range. Also, edema. If they have edema, and they usually do not have edema, they're third spacing from the increased capillary permeability. All right. They can have fluid going into their peritoneal cavity, and the accumulation of fluid there is called ascites. Okay, so it can accumulate, it can push up on the diaphragm, cause them respiratory distress, for which, they can have respiratory distress, starting with the tachypnea and building from there. Their peripheral pulses are going to be rapid with the tachycardia and thready. This is not the same thing as weak. You have strong pulses, you have weak pulses, and thready pulses, when you feel them, they're very light and they come and go. Weak is usually pretty steady. You can continue to feel it. Thready is coming and going, and it's very hard to palpate. Okay. So, that's what starts happening there because of the decreased perfusion and the vasodilation. That edema is going to happen everywhere, not just in the peritoneal cavity, but in the extremities as well. Then you're going to see the hypercoagulability. So what happens is, as that fluid goes from the intravascular space into the third spaces or the interstitial spaces, okay, those platelets are going to start bumping together and going to start clotting. So on one hand, you're going to have probably some liver dysfunction, just because of the bacteria. They like to hit all those nice, juicy, big organs. And so you may start seeing some liver dysfunction. Remember, the liver does manufacture clotting proteins. So if they have a dysfunction in manufacturing the clotting proteins, they're going to have bleeding tendencies with the increased liver dysfunction. So they can end up what's called DIC, disseminated intravascular coagulation, where the body's bleeding and clotting at the same time. Okay, and this is not a good thing. All right, so what are we going to do about these things? Well, for the hypothermia or fever, we're going to end up getting a cooling or heating blanket to kind of balance out the temperature of the patient, okay? Because we don't want them too hot. Their body's gonna be in metabolic overload. Heart rate's gonna, sustain at a high rate, and they're gonna be very tachypnic, and so they can end up with resulting hypoxia if we don't give them enough O2, or if they're breathing too shallow to really intake. We really need to get that O2 to them to prevent ischemia and hypoxia. So whatever delivery system is the best. If we still can't get those O2 sets up, and of course, we're going to also look at ABGs with that. They may have to go on ventilatory support, and a lot of them do, that end up with sepsis, okay? From changes in level of consciousness, they can't protect their airway. A lot of times they end up going on a vent, okay? One big thing that they're going to do is fluid resuscitation with IV therapy, IV fluids, to increase the blood pressure. They have to get that blood pressure back up. So fluid resuscitation and IV vasopressors. Vasopressors being the vessels, pressors meaning, pressing on those vessels or constricting them. And that's going to help to increase the blood pressure. Now, with vasoconstriction comes a price. It's going to shunt the blood where it needs to be, the brain, the heart, the lungs, where the extremities are going to get so vasoconstricted that they will turn blue and eventually black, and patients have lost fingers and actually extremities, with below the elbow amputations, or the hand amputated, or below the knee amputations, or even above the knee, so because, the body those vasopressors just vasoconstrict so much, and those ICU nurses have to turn up those vasopressors to keep that MAP, that mean arterial pressure, around 70, or a high 60s, to try and perfuse the body. And, the more that they have to titrate up, the more vasoconstriction occurs, the more chance they're going to lose extremities. Okay. So the labs, of course, that we're going to look at for sepsis, we're going to look at the CBC and look at the white blood cell count. But not only the white blood cell count, because that's going to tell us, what kind of infection, or as far as how severe an infection is that we're looking at, but also the platelet count. What are the platelets doing? Are they dropping? Are they increasing? What's going on? Blood cultures. Again, we've got to get a sense of what's going on with the organism that's traveling in the blood. Is this a new patient coming in the ER, and we really don't know what's going on with them? So, we're having to culture and look at everything. Or is this a patient that was treated for sepsis, is now on a med-surg floor, and we saw the signs again? So what is it? Is it now another opportunistic infection that has invaded, or did they come down with a resistant bug? All of these things, are valid. So the big thing to get started with these patients, besides getting their blood pressure up, is the sepsis protocol antibiotic therapy. Once those blood cultures are drawn, get them started. But even if the blood cultures aren't being drawn right at that very minute, get them started on those antibiotics. On the med-surg floor, those that have infections, this is still a complication they can have. So don't think just because they're on antibiotics that they can't get septic. They can. Okay. ABGs, like I said, for, to look at the arterial oxygen. Is this patient getting enough oxygen, or are they hypoxic? As well as ABGs are acid base or arterial blood gases, and you're going to be looking at the acid base qualities of that. Okay, and this is going to directly be in result of a very unique blood level, and that's going to be lactate or lactic acid. Okay, and this happens in the presence of bacteria and toxins in the blood. It will increase, okay, and continue to increase until this sepsis is resolved. Okay, so the lactic acid, by very definition, acid, it's going to have those ABGs be on the acidotic side. So we need to treat the acidosis of the patient. Liver function test, very important. Is the liver affected? Most times, yes. It's going to be greatly affected, and that's where you're going to see some of those bleeding problems. Okay, the renal function. The kidneys aren't part of the trilogy, the brain, the heart, the lungs. Okay, so they may, they won't be getting perfused all that much, so you may not see any urine output, or very, very little. So they may have to be dialyzed or go on dialysis. A basic metabolic panel or a complete metabolic panel to look at electrolytes, all the electrolytes, where are they? To make sure they have enough glucose, that they're not hypoglycemic, or are they hyperglycemic? Are they hypokalemic from low potassium or high potassium? What's going on with them? Okay. And then what I have is coag studies or coagulation studies. And that's to see bleeding times and to see where we are with PT, PTTs, INRs, and then again, a platelet count there as well. So they can see a picture of what's going on with this patient as far as, coagulation, especially in respect to the DIC. So the big thing is to keep them from going, well, they go to sepsis, then they can go into the multi-organ dysfunction syndrome, which I have alluded to with those labs, the different things that we're going to look at: lungs, liver, kidney, all those kinds of things. And then, of course, which that can lead to the multi-organ, like I said, dysfunction syndrome with those things, and then septic shock. Now, septic shock is persistently low mean arterial pressures, less than 70, as a result of an overwhelming infection despite fluid resuscitation. Okay, so septic shock is when we have to really start adding those vasopressors to try and keep that blood pressure up, keep titrating it up, and then hopefully they'll survive. Okay, but this is a deadly complication. This is nothing to fool with. Hence the reason when patients come in with fevers, one of the first things they do is get those blood cultures, because they want to make sure to treat sepsis from the very beginning and not to let it go even several hours, because it can make the difference between them surviving and them dying. So I hope this helped. This is all about sepsis. It's just a little intro. I don't go into big drugs or anything. Just, the cues that we can help at the bedside are trending the vital signs, making sure the mean arterial pressure stays between 70 and 100, looking for changes in level of consciousness, increased respiratory rate, tachycardia, fever or hypothermia. Those things we can do. We can even look at, my patient didn't look like this 8 hours ago. Now they kind of look edematous, like they have some edema. With the change of level of consciousness, they could be lethargic as opposed to just confused. They can even be unresponsive. So I just want you to know that as nursing students at the bedside, even on a med-surg floor or wherever, you can make a difference in somebody's life and save a life. So this is the end of the intro to sepsis. Thank you guys for listening, and I will see you in the halls.